Greetings, everyone. Greetings. Xin Chào from Da Nang, Vietnam. It is an honor and a privilege to get to share some of my thinking with you all today at National DNP Week. My presentation is titled Beyond Burnout, Integrating Indigenous Healing Arts into Leadership Renewal. And before I get started, I would love to take the opportunity to invite everyone here to arrive in this present moment with a deep breath. A nice big inhale through your nose and exhale through your mouth. Placing your feet firm on the ground, being aware of your sit bones. Notice what's happening with your shoulders. Release them by bringing them up towards your ears, back down and around, settling in. And just 3 more breaths before we move on to the next slide. Inhale. Exhale. Inhale. Exhale. Last one, the biggest of the day. Inhale. And exhale. Thank you, and thank you for indulging with me. I personally needed that for myself. And so I would love to introduce myself. And I know how to do that by introducing myself through an Indigenous lens. My name is Amaka Akinade. I am the daughter, next slide, of Uzamaka and Ebelechukwu, granddaughter of Mwovwako, Mwarashiono, Chidiobu, and Madabuchi, great-granddaughter of Udu and Ugona, great-great-granddaughter of Akwudumanu, and many of the names that I do not have the privilege to know at this moment. I am an Igbo woman from the rivers of Iwolo and the mountains of Enugu, Nigeria, West Africa. I'm a doctorally prepared nurse, an artist, a culture bearer, and a status quo disruptor. I'm still leaning into that one. I'm also currently in Da Nang, Vietnam on a healing sabbatical. I am a well-being consultant, founder, CEO of Wellness Promoters, LLC, and I'm also an adjunct professor of community and public health at Samuel Merritt University. Okay, next slide. So before I forget, you can take your phone out or screenshot this just in case you want to get a hold of me. At Wellness Promoters, we help overwhelmed healthcare leaders overcome burnout so that they can restore balance, lead with clarity, and sustain high performance. And you might say, how do you do that, Dr. Uzo? Well, scan the QR code and I will send you a guide on how to achieve this outcome if you are interested. Okay, enough about me and the plug. Let's get right into the presentation. Next slide. Okay, so this presentation explores how Indigenous healing arts can inform sustainable approaches to leadership renewal and workforce well-being. So the 4 things that I hope that I get through today is we're going to just look at what the cost of burnout is. Like, what is it doing to our healthcare system? And then we're going to use the socio-ecological lens to identify how we can address this issue. We're going to look at some principles of Indigenous healing arts, look at a couple of frameworks, and then explore what some practical integration strategies can be using the framework. Next slide. All right, so Maslow has been looking at burnout since the 80s, and he actually developed a valid and reliable scale in case you need an assessment to use as a leader to measure burnout, okay? Now, burnout has been conceptualized as a psychological syndrome emerging as a prolonged response to chronic interpersonal job stressors. You heard the word interpersonal, we'll get to that in a minute. Signs of burnout include exhaustion, depersonalization, and reduced personal accomplishment. Anybody experiencing that? I think I mentioned that I am in Vietnam because I am on a healing sabbatical. Okay. Now, these are some examples of exhaustion, and these are some examples of depersonalization and reduced personal accomplishments. So burnout symptoms result in a negative outlook towards self and others. The significance and impact of burnout are far-reaching as it relates to workforce retention and work-life challenges. It affects morale, retention, safety, and organizational culture. All right, so you will be mind blown at the next slide. Next. There is an estimated 190 billion, B for billion, healthcare costs and $225 billion in lost productivity annually. That is B for billion. Turnover cost per registered nurse is $4.75 million per unit annually. And they're looking at about $3,400 per employee average burnout cost. Burnout is expensive. Next slide. So according to the International Council of Nurses report that just came out this year, they came out with an agenda with some recommendations actually, which most of it is about prioritizing nurse well-being, because as you saw in the previous slide, it's costing healthcare and the society a lot of money. But it's not just money, right? It is a global crisis in our well-being. And how are we able to care for people if we are in crises? We are having elevated psychological distress. And of course, the nurses are not staying, they're leaving. So retention and attrition is a problem. Next slide. These numbers often shift, but there is about approximately 60% of acute care nurses that reported burnout post-COVID, and leaders are facing moral distress and organizational strain currently today. So we're gonna move on to the next slide because I just wanted to give you an overview of how critical burnout is currently at the state of burnout. So systemic drivers, yes. So the systemic drivers include administrative burden, equity gaps, and value conflicts, especially when we are in crises. Next slide. We actually have the potential to mitigate burnout, to protect ourselves from burnout. I love this image because it shows the caterpillar to the butterfly. And when the caterpillar is in its cocoon, it is difficult to see what is possible. So I just wanted to bring in a fresh breath to show that transformational and authentic leadership styles can actually protect us against burnout. This has been going on. This was published in 2018. So transformational and authentic leadership is no longer a buzzword. There's research that shows that it enhances meaning and relational trust, which also I will talk about moving forward. So in this next slide, we're going to move into the framework, the lens at which we're using to look at burnout. Okay, so in 2022, the Journal of Public Health published an article titled "Promoting Burnout Prevention Through a Socio-Ecological Lens." Those of you who know about public health understand that we cannot just treat an individual, right? If an individual comes in with some ailments, it's not just the head to toe that we're looking at. We're looking at where this person lives, where they work, where they play, where they pray, right? And so this socio-ecological model is allowing us to look at burnout the same way. Right at the core is the individual, of course. A lot of the work that I do at our consultancy is addressing the individual. You cannot not address the individual. However, it's really important to look at interpersonal relationships, organizational relationships, community relationships, and the systems in which the systems that hold all of these things together. So if it's broken at the systemic level, and if it's broken at the organizational level, you best believe it's going to trickle down to the individual. So this model suggests an interconnected factors at various levels. The model aims to decrease burnout by emphasizing both personal and environmental factors, forming a holistic system to address the issue. So burnout is really complex. I didn't go into all the reasons why we are burned out. That's not what this presentation is about. It's about understanding how complex it is. Of course, we have to treat it at the root cause, but sometimes we just have to stop the bleeding, all right? So it must be addressed at each level, especially, guess what level? Not the individual level, but at the systemic level. Next slide. All right, so as you can see, this is my way for us to just have a look at what the individual level is, right? It's just the one person. Interpersonal level, that's between you and your coworkers, you and your supervisors, you and the patients, you and the community members, you and your family members, you and your constituents, right? And then the organizational level, this is the entity that is funding the practice. This is the entity that is housing you. This is the organization in which you work for. And then, of course, the community society level, that's like the city or the county or the country or the globe even, right? There are systems in place. There are policies in place. I know that the speaker next to me is going to speak all about policy and advocacy, but this is why it's important for us to understand all the levels at which intervention can take place, especially for burnout. Okay, all right. Take a deep breath. The doom and gloom is almost over. We're moving on to the next slide. All right, so Indigenous healing arts and Indigenous ways of knowing. So just a disclaimer on the word Indigenous. The word Indigenous can mean different things to different people. And the United Nations describes Indigenous groups as having unique knowledge, languages, and strong connections to their land. There's the environment again. They point out that Indigenous peoples' experiences vary a lot around the world because different histories of colonization and because of different histories of colonization and social conditions. So in 2022, there was an article in the Disability Studies Quarterly, Ned and his team. They mentioned that being Indigenous isn't something that's fixed, it's living. It's a changing identity that has been shaped over time by colonization. So I just wanted to frame that. I'm not necessarily speaking specifically to indigeneity within the context of Native America or the North America Turtle Island. I'm speaking beyond the country, worldwide, globally. I identify as an Indigenous Igbo woman from Nigeria, West Africa, for example. Okay, next slide. So this beautiful artwork I created, y'all, okay? And the Indigenous Holistic Framework was developed by Pigeon in 2012. One of the frameworks that I'm going to talk about, I'll share three actually today, two Indigenous frameworks today, and then one framework that we need to discuss, is that the Indigenous Holistic Framework is grounded in the 4 R's: respect, responsibility, relevance, and reciprocity. Respect, responsibility, relevance, and reciprocity. It teaches that true wellness and knowledge comes from maintaining balance among the physical, emotional, intellectual, and spiritual realms. This framework reminds us that everything is relational. Everything is relational. Relationship with yourself as an individual, relationship with your interpersonal relationships, relationship with the organization that houses you, relationship with the society in which you live in. Our well-being is connected to ourselves, our land, our ancestors, and if you don't believe in ancestry, the epigenetics in which you come from, so your blood and where it came from, and our communities. And that strong leadership means continually renewing and balancing all of these dimensions. Next slide. So that was the holistic Indigenous framework by Pigeon. The next framework that I would love to introduce or share is the Ubuntu. Now, many of you may have heard of this framework. Ubuntu is an African philosophy from Southern Africa, especially amongst the Zulu and Xhosa people. And that means roughly means I am because we are. I am because we are. It's all about the idea that we become human through our relationships with others, and that kindness, respect, and community makes us who we are. The main pillars of Ubuntu are humanity, compassion, sharing, and harmony within the community. Pillars of Ubuntu are humanity, compassion, sharing, and harmony. All right? So how does this play out in leadership? Bayou published an article just this year, and he talks about how there's this moral reciprocity. So that's community over individuality, healing through interconnectedness and compassion, collective accountability and care. And they also reinforce that renewal is not self-care in isolation, but communal restoration. I'll repeat that. Leadership renewal is not self-care in isolation, but communal restoration. So how many of you have been asked to go take care of yourself? Go take care of yourself and then come back, right? That is self-care in isolation. And if we're talking about care, if we're talking about collective accountability and care, if we're talking about community over individuality, if we're talking about leadership renewal, this needs to be done collectively from an Indigenous framework. It's not an I, it is a we. I am because we are. Okay, next slide. So I just shared 2 Indigenous frameworks that we can use to have a look at addressing burnout. But I have one third one that I just could not help but to include. Now, if you look on this screen, this image comes from the Racial Equity and Liberation Learning Community that was created by Monica Dennis and Rachel Ibrahim. The name of the program, you can look it up, it's called Move to End Violence. And this image struck me when I was in their program quite a few years ago. And I just had to do a screenshot because it helps me remember. On the left, you can see, and we are, when you are sitting and you are housed in the system of oppression, this is what happens to you. Systems of oppression disconnect people from their source. It disconnects you from your story, from your emotions, and from your body. The disconnection leads to distortion, disassociation, and emotional distance, keeping individuals separated from humanity, keeping us separated from source. This is intentional, okay? And over to the right, you would look at the difference between the left and the right liberatory practices. Liberatory practices seeks to reverse this process, to reconnect people to their source, reconnect people to their story, to their emotions and body, and encouraging restoration, re-engagement, and reclamation of wholeness, right? We are whole individuals. We are whole beings. We're not just a nurse. We're not just a healthcare provider. We're not just a leader. We're not just an administrator. We're not just women, right? We are whole beings connected to land, community, ancestors, environment. And all of these align with transformation and trauma-informed renewal. Okay, so we're moving on to the next slide. And here, we're going to look at some application, some integration from some of these concepts to practice. Okay, next slide. So I made a table with just some examples of what intervention can look like at each of these levels. So for example, at the individual level, this is where we're talking about self-regulation and self-care. How do we self-regulate? Usually through breath work, usually through expressive arts like journaling, mindfulness, taking time off work, having increased pay, making sure that you're feeling psychologically safe, all of those things. But from a leadership perspective, it's really important that leaders make this available. Don't gaslight your staff. Don't gaslight yourself. There needs to be resources available for folks to engage in these practices, right? So we've got the interpersonal, which is the culture of open communication and trust at the organizational level. Some examples are like peer support, team reflection, a reflective culture, healing circles. And then at the organizational level, this is where we're talking about safe staffing, psychological safety, relational governance, policy, the big P word, right? This is where the Maslow assessment tool can come in handy, where we're frequently assessing teams to check in on their level of burnout, but also we're looking at a training on burnout prevention and culturally inclusive well-being programs that is embedded in the culture of the environment, not just one-offs, right? Renewal retreats that is for the people, not at the people. Okay, expressive arts integration. And then of course the policy and the system. Show me your money, show me your budget, and I'll tell you what you care about. So we're making sure that it is a budget line item, all right? That is a recommendation from the International Council of Nursing that put out the agenda this year, teaching us about what we can do to ensure that we're prioritizing the well-being of nurse leaders. Okay, moving on to the next slide. Now, here are some practices for us to consider. Yes, expressive arts and art therapy. And do you know why? Because expressive arts provides symbolic, nonverbal ways to process stress, to access emotions, to cultivate meaning in community, to be able to reflect when you don't have the words, and to be able to integrate when those words are insufficient, all right? Expressive arts have stronger empirical support now, including randomized control trials that bolsters their legitimacy as interventions, not just nice add-ons. This is something that Indigenous people have known for a long time. We've also have group art-based programs that significantly reduce emotional exhaustion and stress amongst healthcare professionals. There was a study that was done most recently, a 2025 study. It was like 27 studies over 13 countries. And they've shown that it restores meaning, emotional regulation, reflection, and community connection. The return on investment on these, y'all, is low cost. It's low cost, okay? So we also have breath work, okay? There's a ton of randomized controlled trials that have proven that, that it regulates autonomic nervous system, it enhances calm, it enhances focus, and you need minimal training. It's a minimum training cost, and it is scalable. It can be happening on site or virtually. We have Indigenous healing arts practices, y'all. Make sure that you are bringing in somebody who actually knows what they're doing and not appropriating, but appreciating the cultures. It also helps us remember who we are, to reconnect, all right? There are some examples of these, like healing circles, ceremony, drumming together, dancing together, singing together, playing together, being in nature. Land-based programs are effective. Okay, moving on to the next slide. All right, so just in a nutshell, okay, the return on investment for addressing burnout is high, okay? It does pay off if you invest in making sure that there's adequate staffing, there's adequate reflection time, there is psychological safety and trust so that folks can lean into their healing. Next slide. Okay, all right, so I actually created this image also myself, and I want to go on to the next slide where you can see some examples of this work in community settings. When I was in Ohlone territory, which is also known as Oakland, California, and the Sacramento area, I was invited by various organizations to bring in these group healing circles, the drumming, the singing, the dancing, and the outcomes revealed increased peace, increased connection and clarity, reduced fatigue and stress. And a lot of the activities included drumming, altar making, herbal medicine, journaling, and so on and so forth. So the next slide. We also have it done in academic settings. This is where students are able to, these are master prepared students that are in their DNP program, and they're learning about how to mitigate the stress before they go into the field. And so you can see the sound bowls there to the right. They created their vision boards, through collaging, and over to the right, there's a healing sharing circle that's happening there. And the results it's all qualitative, but they're all sharing that this is helpful. Okay, next slide. So, just bringing it full circle, I just wanted to share that we talked about the cost of burnout, what is costing us in society. We talked about using the socio-ecological lens, right? Because it's complex. You cannot just tell an individual to go take a nap and come back. No, it needs to happen at each of those levels: individual, interpersonal, organizational, and systemic. We also explored some practical integration strategies that leaders can utilize at each of these levels. And of course, why we're using the Indigenous healing arts model. Okay, next slide. So here's a reflection question for you all before we end today. What does renewal mean to you as a leader? What does renewal mean to you within your team, within your community, and within the system in which you live, work, play, and pray? Okay, and next slide. That is it, folks. Thank you so much. Please take a screenshot of this. This is my LinkedIn QR code. You can also find me on TikTok at Wellness Hacking. And I really appreciate that you all took the time to listen to me speak. Now, the next set of slides are the references in case you want to just kind of scroll through. And if people want to take a snapshot of that, that is great. Thank you so much and have a wonderful day.
Oh, yes, yes, get your flowers, all the cheering. That was fantastic. Dr. Nwankpa, thank you so much for um, sharing and defining Indigenous. That was really helpful for me on a personal level. I'm checking the chat for questions for Dr. Wangpa, and while those are coming in, I have a question for you, and I hope it's okay to ask this because knowing that you're in Vietnam and on a healing sabbatical, there is a cynical part in me that goes, well, of course she's balanced. Of course she's light and airy and all of these things, you know? But incorporating this into daily practice, you talked about breath work. You talked about healing in community versus isolation. And I think that is something that feels often inaccessible, at least for me. The only community like that I am familiar with in healing regularly in that way is the church. And I think that a lot of it works for some people and for other people not so much. So I'm curious about um why Vietnam and also for those of us who sometimes feel like everything is appropriation. You know, I can't name my ancestors the way you did. That was beautiful, by the way. And you say you call yourself Indigenous Igbo woman. I feel like as a Black American, that's lost on me. Like I am Indigenous what woman, right? So I'd love to hear more about that and in your, what's why Vietnam?
Okay, so there was a lot that you
I
brought up.
know. Sorry.
But before I go into the why Vietnam, I wanted to talk about indigeneity, right? Connection to the land, connection to your ancestors, connection to your community, connection to the languages spoken. African Americans have languages. These languages are spoken specifically within the African American communities. When you look at these languages, whether you are in South Carolina, Brooklyn, you would hear the truth, the spirit does not lie. It is there. It is one to be proud of. African Americans tended this lands, grew all the food, the cotton, connection to the land. African Americans were brought, not all of them, they were indigenous Black folk on Northern American lands, but also African indigenous people were brought here. When we talk about ancestry, we talk about that ancestry, the oldest people on the planet, right? Connection to land, connection to community, connection to languages. This is what I'm referring to. Not talking about the context in which we describe it today, like only a certain people have access to this. It is a way of life. It is not a label. I'm privileged to be able to connect it to Igbo. However, if you are connected to the land, I know Igbo people that are not identifying as indigenous because of colonization, pulled us away from our language, pulled us away from the land, pulled us away from these ancient ways of knowing. So it is an act of resistance to go back to these ways of knowing and being. It is not something that only a certain people have access to. It is your right as a human living on this planet. Europeans also had their indigeneity stolen from them. And so it is an act. This is why a lot of appropriation is happening, because people are scraping and trying to get closer to indigeneity somehow. So they find somebody's and they take it and they claim it. But really, by connecting with yourself and your source and being in community with folks who are connecting with land and language, this to me is what I believe helps us reclaim our indigeneity. Okay, all right, so that's just, so that's just to respond to that, because it is, and like I had mentioned, it is a hot topic. It is a hot topic. Yes, I understand that.
And I do want to keep space for other questions? Since I asked you 17 questions in my one, I wanna, that's great. I'm gonna hold that and close, and I think we all appreciated that. Does anyone else have questions for Dr. Nwankpa? Going once, because we've got two more incredible speakers lined up tonight. Going twice. I hope you got those QR codes. I sure did. Uh, Arwise or Arwaisi. Yes, hi.
Hi, good evening.
Good evening.
Great presentation. Thank you so much for everything you spoke about, well-being, leadership well-being, taking time for ourselves, and the question that Mr. Dr. Nixon, or soon to be Dr. Nixon, asked. And to just hear your answer, and even in your introduction, it made me feel really happy as a Ghanaian American. It made me feel really happy because I get the question all the time, why am I asking my daughter to speak Chi? And I'm like, I want her to be connected, just like you said, I don't want her to be just lost in the middle and not know where she comes from. So thank you. Thank you for talking about this and standing up for that, because sometimes it's so hard to even just be brave and do what you're doing. So thank you.
Thank you. Colonization is a disease.
Yep. Some of us really understand that.
Yes. Wow. Who knew that this week would be full of such richness? I want to introduce our next speaker, Dr. Dani Brochu, who's going to, if you want to go ahead and start sharing or setting up your share, Dr. Brochu, I will continue with the introduction. But here we are. This is midweek in DNP's National DNP Week, and Dr. Dani Brochu is an administrative nursing supervisor at Hartford Hospital on translating frontline insight into policy action from the clinic to the Capitol as a DNP competency. I'm so excited for this talk. Take it away, Dr. Brochu.
Hi, thank you, soon to be Dr. Nixon, for that lovely introduction. Can everyone see this? Is this in presenter view? I hope not. It looks okay.
It looks great.
Okay, fantastic. Thank you. Well, good evening, everybody. I'm Dr. Dani Brochu, and thank you to our previous speaker for that absolutely incredible talk and being so vulnerable with your insights. I too am a first generation American. My folks are from Fontefouche, which is a little village in France. And even though I grew up in the early 90s, it was highly discouraged to speak anything other than English in schools. So my French is not nearly what it should be if colonization and ethnocentrism and all those things were not harming folks from all over. So amazing insight into that. But now that we're all relaxed from that talk, we'll get a little fired up about what's going on as far as advocacy goes at local, state, national levels. So before we get started, just a brief disclaimer, I do not have any kind of contracts, financial relationships with any of the organizations or resources that I'm going to be talking about tonight. This is strictly just for information sharing. Some of you may know about some of the things we'll discuss. Some of these things may be new to you, but I am all about sharing of information. So from the foundational classes of undergraduate nursing education, we're taught that engaging in advocacy and the political process is not only a privilege, but an obligation. So the ANA Code of Ethics, which was just updated over the past year, has been rewritten to include an enhanced focus on the role of nurse advocacy. The key word in this provision is responsibility, which further reinforces that nurses have a fundamental duty to serve as advocates beyond the bedside. Code goes on to provision 9.5, which calls upon nurses and nursing organizations to be actively involved in the political process and the policymaking process. Additionally, the AACN Essentials for Graduate Level Nursing Programs, which of course includes DNP programs, includes 10 domains. And one could argue that all 10 are related to policy and advocacy. However, Domain 3, which focuses on health of populations, explicitly outlines utilizing the nursing process to influence policy change in a way that positively impacts our most marginalized and vulnerable populations. So whether we like it or not, nursing is political. Nearly every federal policy, from Medicare and Medicaid reimbursement to research funding and HRSA grants to APRN Independent Practice Authority, and everything in between. Decisions made in our capital and at the state level affect nurses and patients in every single community. So why is it easy to feel alone in this fight? There is no one true solution to this issue, but there are certainly a few root cause factors to consider. Rampant burnout, especially among bedside nurses, is an international issue. Nurses frequently work too long, demanding shifts, and may feel too exhausted or overextended to participate in advocacy or political activities outside of their normal work hours. Additionally, many nurses feel that the care they give to their patients at the bedside is enough and don't feel the need to advocate on other levels. Limited political knowledge is another notable barrier. Many nurses feel they lack the necessary understanding of the political process, legislation, or policymaking in general to engage confidently in this work. Public speaking, how to correspond with government officials, and similar skills are not something that every nurse is comfortable with and not something that's taught to the same extent in every undergraduate nursing program. These skills need to be taught and learned with great intention. More pervasive still is the perception of powerlessness. Many nurses believe their voices will not make a difference in shaping healthcare policy, which can lead to disengagement or apathy towards political involvement. Depending on whether or not you are a member of a healthcare union, workplace restrictions and fear of repercussions may also come into play. Nurses may feel that their activism could conflict with employer policies or negatively impact their job security or other professional relationships. When considering the levels of advocacy, remember that local is global and global is always local. Think of the downstream effect of lawmaking decisions made at national and state legislative chambers that are signed into law and affect thousands of programs that so many of our patients rely on. For a nurse who is new to advocacy, the thought of participating in a global work group can seem very intimidating. So starting small can create an easy win and build confidence. Never underestimate the power of town government. Attending town halls and getting to know your local lawmakers will help you understand the specific issues in your geographic area. And you can familiarize yourself with key stakeholders for maximum impact. On the state level, each state follows their own process for legislative sessions, how bills are introduced, and how schedules of upcoming open public commentary are published. Signing up to testify publicly enhances nursing visibility and enables nurses to present well-researched and thought-out persuasive arguments to those that matter most in the lawmaking process. On a national level, it's important to know the senators and representatives who represent you. Familiarize yourself with their websites, and it's relatively easy to find their contact information. And most of them have a relatively large team of staff dedicated to getting back to folks. Sending an email or setting up a time for a phone call or in-person meeting can be incredibly impactful. And then finally, on an international level, American nurses have more in common with nurses from other countries than we think. Issues such as access to care, rising rates of obesity and diabetes, food insecurity, and high maternal mortality rates are just a few of the multitude of pressing issues that challenge global communities. Nursing groups such as Sigma and International Council of Nurses work with the United Nations and other non-government organizations to amplify nursing voices on these key issues. When advocating in any arena, going in with a clear strategy and actionable goals is key. Evidence-based advocacy is key to giving lawmakers the facts to make informed decisions. Remember that you are the expert, not them, and they may have clarifying questions for you after your testimony that may surprise you. Prior to writing your letter or setting up a testimony, take some time to do deep homework. Research the facts surrounding the issue from credible sources and building statistics into your pitch to enhance your credibility and get people's attention. Partnerships are also a powerful advocacy tool. There's strength in numbers, and as the single largest sector of the healthcare field, nurses certainly have the numbers. Whether through your state's nursing association or another group such as the Emergency Nurses Association, submitting testimony as a group can boost confidence in those who are engaging in advocacy for the first time. Reaching out to formal media such as the news, podcasts, or local radio shows to amplify your voice is also an underused but excellent tactic. Nurses are sorely underrepresented in the media, and many media representations of our profession are harmful and even sexist. Think about all those naughty nurse costumes that are out in the stores right now. Using your own voice and expertise to portray our profession in an accurate and healthy way also helps to build credibility. And storytelling is one of the oldest and most widely understood ways of conveying information. Based on the issue that you wish to discuss, think back on a time that this directly impacted your life, your practice, or the life of a patient. The emotional response elicited from stories makes it more memorable and helps to move others to care for your cause. Still scared of politics? No worries. Serving on a board of directors is a different but effective way of leading change, whether it's within a nursing organization or somewhere completely outside the realm of healthcare. Board service is incredibly rewarding and can help you build new skills and make valuable strategic connections. I sit on the board of directors for an organization called the Health Collective, which focuses on LGBTQ plus communities, as well as HIV positive individuals to connect them with medical and dental care. I am the only nurse on the board. We have a lawyer on the board. We have a hairdresser on the board. We have a construction worker on our board. We are a ragtag crew of people for sure, but having that group to connect with where everyone has such a different personal and professional take on things is what really leads to our success. So it's a great way to kind of open your eyes and broaden your horizons. These are just a few other political action items that I have found useful in the past. The first one is called 5Calls. It's an amazing app that you can download and use to contact legislators about key issues. All you have to do is input where you live, along with issues you're interested in advocating for, and it will provide you contact information and even scripts to use if you're nervous or you're not a very strong off-the-cuff speaker. You can also report if and when lawmakers contact you back, which upholds their accountability as well. Healing Politics is another great organization I've found. It's a nonpartisan nonprofit that helps nurses prepare to run for office. So whether you're trying to secure a seat on your town council or running for governor of your state, whatever level you're looking at, this group has an annual retreat and some other events and webinars throughout the year to assist non-traditional political candidates such as nurses with the tools and strategies that they need to build their campaigns. And while there are hundreds of nursing special interest groups that focus on different goals, I'm sure almost everybody on this call is at least a part of one or two of those groups. The summation of these groups shows the power of thousands of nurses collaborating and combining resources to achieve common goals. For example, the Alliance of Nurses for Healthy Environments focuses on sustainability and environmental health. DNPs of color works on health equity and advancing DNPs of color in our professions, etc. So that is what I have for you this evening. Short, sweet, and to the point. Thank you so much for having me. I was a bit nervous, but I'm very grateful for this opportunity, and I will stop sharing, and I'm happy to take any questions. Yay, thank you, everybody.
I have a question. Have you gone through the Healing Politics campaign school?
I have not yet. The very strong key word here is yet.
Yes. Okay.
I'm actually back in school for my MBA right now. So once that's done in 2027, then we'll see.
Excellent. We do have one of our DNPs of color, Dr. Yvette Conyers, who has been through it. So if any of you know her and are interested, she's gone through the campaign school, which is pretty neat. I am looking in the chat for any questions for Dr. Brochu. MBA. Okay.
Soon to be.
Soon to be. No, it's great. I love it. I love it. Well, folks, these are just so rich and so informative. Some things we know and are being reminded of. And, you know, I did speak at the conference on advocacy playbook on our conference last week, and I compared advocacy to football just to keep it fun. And in that comparison, we are in the preseason. This is training camp. This is preseason. This is the time to get our ducks in a row and think about what are our advocacy priorities. Are we going to be leveraging our voices with organizations, excuse me, boards, like you mentioned? Nurses are strong in number, and we can really get some things done. I want to introduce,
Absolutely. I think one of the
yes,
speakers on Monday who also talked about advocacy talked about the Nurses on Boards Coalition, which
yes.
is actually how I found my board. You just input your credentials, what you're interested in. Every now and again, you'll get an email from a board that would match up with you in some way, and you can dig into all the information they send you to kind of look at the responsibilities, look at the organization, and it's like a matchmaking almost.
Nurses on Boards Coalition.
Yes, I will
I will
put it
be
in the chat.
taking that to my students. Thank you so much. I love that.
Absolutely. Thank you.
All right, y'all. Our third and final speaker for the night is Dr. Amaka Akinade.
Oh, that was very good.
Oh, is that correct?
It was really Amaka Akinade, but that's close.
Okay, Amaka Akinade.
Mhm.
All right. To close us out with NP and Advanced Wound Ostomy Specialty on Practice Meets Power, DNP-driven interdisciplinary solutions in wound care that improve access and healing outcomes. I'm going to go ahead and share your slides, and whenever you would like for them to be advanced, just say next slide.
Okay.
And we are, oops, we're almost off to the races. Let me get us in the slideshow
Are
here.
you able to see me okay?
I see you.
Okay.
And are we able to see the slides as well? I think so.
Yes.
All right.
All right. All right. Good evening. My name is Amaka Akinade. Thank you all for hanging in there and coming to the presentation. I'm happy to present my presentation, DNPs Driving Interdisciplinary Solutions in Wound Care. So if you're eating dinner or just about to eat dinner, you may proceed. There's no wonderful, gooey, draining wounds in this particular presentation, so shame. But so proceed, it's going to be okay. So no big type of wounds in this presentation. So I'd like to go ahead and with that, get started. So as a doctor of nursing practice professional, we play a critical role in addressing complex health system challenges through evidence translation and innovation. So our doctoral preparation equips us with the advanced skills in systems thinking, leadership, and interprofessional collaboration. So we are leveraging these competencies to bridge gaps between bedside practice and policy to ensure that care is evidence-based and outcome-driven. So we design and lead quality improvement initiative. We optimize workflows and foster environments that support continuous learning. So we're also using data to drive decision-making and align practice with institutional priorities to help us enhance efficiencies, improve patient outcomes, and also strengthen healthcare equity. So our ability to integrate research, leadership, and clinical expertise positions us as key drivers of sustainable health system transformation. So particularly in wound care, our role as a DNP extends across clinical, educational, and leadership dimensions. So we're translating research into practical interventions, ensuring evidence-based protocols are guiding assessment and treatment. And we also serve as liaisons between the clinicians, administrators, policymakers to unify goals and also to streamline patient care. So by leading interdisciplinary teams, we are ensuring consistency in practice through frameworks such as time and WOC guidelines. We also are very good at mentoring nurses, fostering clinical competence and autonomy. So as leaders, we're evaluating outcomes and that drive continuous improvement. We're advocating for system redesigns that support timely, equitable wound management and improved healing trajectories, specifically in chronic wounds such as partial injuries, diabetic ulcers, and venous leg ulcers. So in venous leg ulcers, or commonly called VLUs, they're among the most common type of chronic wounds. They affect about 1 to 3% of the US population. They occur when the valves in the lower extremities are malfunctioning or they're not working anymore. So it causes an issue with blood flow returning back up to the heart. So they're often very recurrent, they're painful, they're associated with reduced mobility and a diminished quality of life. Those at risk are those who have a history of a blood clot, maybe genetic, maybe a mom or a dad or family member have varicosities or a history of venous leg ulcerations, or maybe there's a occupation that require a lot of sitting and standing. So all these risk factors put patients and put people at risk for developing venous leg ulcerations. So the average healing time for VLUs can exceed 20 weeks, and then delayed access to specialists further prolongs recovery. So contributing factors include poor venous return, obesity, aging, inadequate adherence to compression therapy. And then these type of challenges really highlight the urgent need for standardized evidence-based intervention and timely multidisciplinary care. So as DNPs, we can address these barriers by improving access, educating providers, and implementing data-driven protocols that enhance healing outcome. Okay, so the next slide is what's the issue?
Yes, please
So,
let me know when you want me to go to the next slide. There was a little lag there.
okay, I'm
My
sorry. Okay, so we're on the
apologies.
slide of the what's the issue?
Yes.
Okay, thank you. So in the what's the issue? So in my particular institution, we have about 37 clinics all across the greater Houston area. And so I joined my institution in 2018. And so we hired on another APP, so physician assistant, in 2022. So you can imagine in over like 37 clinics all throughout the greater Houston area, internal medicine providers, family medicine providers, podiatry, vascular surgeon, anyone that had an issue with the wound was referring them to only two providers. And so you could imagine the sheer number of patients that we had to manage. It was at least over between like 2018 and 2022, each year between 4,000 and 5,000 referrals that were received in the clinic. And so there's two locations. I'm located in the central area of Houston, and I have my colleague who's located in the north area of Houston. And in my particular clinic in the central part of Houston, that's where most patients were concentrated. So my patient capacity or my clinic capacity was always in like the 90th percentile. So I saw a lot of patients, just me, a nurse at LVN, and also a medical assistant. So you could imagine the sheer number of patients. It was just me, and it was a delay in access and accessing wound expertise. And so patients who were referred to my clinic, they typically had to wait about 3 weeks, so to about 21 days. So imagine you or a loved one having an open sore, draining, painful, you're unable to go to work, take the kids to school, what have you. And then you go to your primary care doctor who's telling you you have to wait 3 weeks to get into the clinic, or you're calling the clinic and they say, you know what, we don't have an availability for 3 weeks. So this was very frustrating to patients, very frustrating to myself. And at the time, our institution was not able to put the job posting for another wound care provider. So it was incredibly frustrating to try to manage these patients who were unable to get into the clinic in a timely manner. So because they were unable to get into the clinic in a timely manner, the challenges was risk of complications, risk of infection, and just maybe even going to the hospital, possibly even amputation. There was documentation inconsistencies, insufficient provider training and wound assessment, and there was also a lack of like standardized workflows that perpetuated the suboptimal care with our patients. Okay, so the next slide, gaps in current wound care. So when we look at the current wound care delivery, it was inconsistent with delays in the specialist referral and treatment initiation. So again, it was averaging between 19 and 21 days before patients could access the wound care specialist. So I remember it was, I think it was a Wednesday actually, and it was in 2018. And I was in my office and just really incredibly frustrated, honestly, because I would go to these quarterly meetings with administration. I felt like I was begging, honestly. I felt like I was begging for another wound care provider. I just needed someone there who can also see patients, because currently it was just me, again, an RN, an LVN, and a medical assistant. And I was being told that we had enough staff, we had to work with what we have, basically no. And so I was incredibly frustrated and at my wit's end. And I think it was at that time actually that I decided that I just needed to change the way I thought about it, because I knew that we weren't going to get another advanced practice provider. So I knew that I needed to work with who I have. I had to work with the staff that I had. So that's what actually helped me to propel me to go to pursue my DNP. I just needed a different way of thinking and how to change the system and to make it more beneficial for our patients. Because currently the way that things were going, it wasn't working. And so as a DNP, and especially going through the program, it really kind of opened my eyes into the way how we could redesign and go into the literature and researching different strategies and different ways that we can really optimize the wound care and really improve access to our patients, and particularly our more vulnerable populations, especially those that were in the rural or low resource areas. Because these patients experience longer delays and poor outcomes. So the gaps highlighted the systemic inefficiencies in inequities in care delivery. So as a DNP, I found myself in a very unique position to close these gaps through education, protocol, standardization, and implementation of a quality improvement framework to emphasize timely access and interdisciplinary collaboration. So after reviewing the literature, we discovered that we could actually use a nurse-led model to improve the access to patients who were suffering from chronic venous ulceration. Okay, the next slide, the equity lens. So we know that equity must remain at the center of any strategy for improving wound care outcomes. So disparities in access, timeliness of care, and outcomes are very well documented. So patients from socioeconomically disadvantaged groups, rural areas, and certain racial and ethnic minorities face greater delays in specialist assessment, and they often have worse healing trajectories. So these inequities are driven by multiple factors, including issues with transportation, financial barriers, limited availability of wound care experts, lower health literacy, and also social determinants such as unstable housing and food insecurity. So addressing these gaps require both a clinical and system level intervention. So we needed to emphasize the need for targeted outreach and culturally competent care, as well as even explore like telehealth services and mobile services to reduce geographic barriers and to improve the outcomes. Next slide. The DNP as the integrator and innovator. So the DNPs are uniquely positioned to serve as both integrator and innovator within the wound care system. So our integrative functions as coordinating interdisciplinary teams, embedding standardized assessment tools into clinical workflows in the electronic health record, and developing clear referral pathways that reduce delays in care. And as innovators, we lead the adoption and evaluation of new care models, such as the nurse-led clinic and then telehealth monitoring and digital wound care assessments. But it's equally important that we ensure that all implementation efforts remain both evidence-based and equity-oriented. So the evidence does show us that the nurse-led and advanced practice nurse-led models improve healing outcomes. So in my institution, what we did in addition to doing the nurse-led service, we were all kind of like in a group chat. So we had the discipline, a representative from each of the disciplines in a group chat. So whenever we saw a patient in particular with like a venous leg ulceration, we had a representative from like endocrinology, from vascular surgery, from podiatry, or just from whatever discipline that patient may need. So we were all kind of in clear and consistent communication with each other. So if a patient needed a particular service, we were able to get that patient expedited into an appointment. So that really proved to help patients get into where they needed to without a delay. So the DNP's training and quality improvement, health system science, and translational implementation positions us to scale these models and for sustained success, measurable outcomes frameworks, stakeholder engagement, and funding strategies. We were able to evaluate these models. So as DNPs, we need to synthesize these elements and translate this into long-term system-wide transformation. Okay, next slide. Okay, the interdisciplinary wound care in action. So we know that effective wound care does not happen in isolation. And I know I heard you earlier say that you gave the analogy of a football or a football team, and that's very fitting because also I kind of think of it that way in wound care. You know, you have your like DNP who's maybe like the quarterback. For instance, like my husband, he's a huge Dallas Cowboys fan, and my son is playing football. He's in his second season. And so I'm learning all about the different positions, outside linebacker, the quarterback, the tight end, defensive. So all these different is all new to me. So I'm learning all these different positions on the football team. So that's kind of how I think of it of wound care. So, you know, you have your central person, the DNP, and then they're kind of like the quarterback. So each person kind of has their own specific specialty. So you have to coordinate with the nurses and make sure that the nurses are really practicing to the top of their scope. You know, you're coordinating with different physicians, whether it's vascular surgery, dermatology, infectious disease. You're coordinating with case management and social work, as well as PTOT, dietitians, and podiatry. So we know that wound care really requires a collaboration among multiple disciplines working towards a shared goal. So either making that touchdown or preventing the other team from making the touchdown. So we're all working towards a common goal. So the interdisciplinary models bring together the nursing, medicine, physical therapy, nutrition, pharmacy, social work, all together to really address the complex biological and psychosocial dimensions of chronic wounds. So evidence does show us that a coordinated team approach leads to faster healing times, fewer complications, and greater patient satisfaction. Okay, next slide, please. Okay, so the DNP as an advocate. So in the nurse-led service project that we implemented, advocacy means really championing for timely, equitable access to wound care by empowering nurses to practice at the very top of their scope. So I advocated for the workflow changes that allow trained outpatient nurses to manage leg ulcers using standardized evidence-based guidelines, reducing delays, and improving healing times. So what I needed to do was collaborate with the education team and make these different PowerPoint presentations. We used case reviews, studies, one-on-one mentoring. So the nurses felt very comfortable in managing these venous leg ulcerations. So what happened in this project is instead of patients coming directly to me, patients were screened beforehand, and they were deemed not complicated, meaning that they didn't have too many comorbidities, or it was a very kind of straightforward venous ulcer, then they were able just to see the nurse, the RN, who was able to see the patient, do a wound assessment, make a wound treatment plan, and follow up with the patient on a weekly basis. So the initiative demonstrated how a DNP-led advocacy can influence system-level change and promote policies and recognize nurse-led models. I will say we were training the nurses. They were very excited, on board to really take charge and again, to really work at the top of their scope and to manage these very complex patients. Okay, the next slide. The DNP as an educator and mentor. So the DNP role as an educator and mentor was very central to the success of this project. So in collaboration with the education department, we provided the structured training on the time tool and WOCN guidelines. We needed to make sure that we were ensuring consistency and confidence in these nurses so they can implement these evidence-based wound care. So it was important that each team member was educated in accordance to their license, and they were working to the top of their license. And we were making sure that we were educating the nurses and mentoring them through case reviews, skill reinforcement, and clinical decision-making to help them grow into independent practitioners capable of delivering high-quality care. So the educational investment, even though we spent weeks doing education and one-on-one training, it was definitely well worth it. It improved our healing outcomes and it really built a long-lasting workforce, and the nurses really built their confidence and able to take care of these patients. Okay, the next slide. Evidence of impact. So the nurse-led service project produced measurable improvements in both the healing outcomes and also access to care. So before implementation, patients with the venous leg ulcers waited an average of 19 to 21 days for a wound visit with me, with a provider. And then it required almost about 104 days until healing. And then after we implemented the nurse-led project in our institution, we were down to an average time of 8 days for access to a wound care expert and 48 days for healing time. So this was definitely a statistical significant difference. And the results highlight the effectiveness of empowering trained nurses to provide evidence-based wound care under the DNP leadership and demonstrating that a coordinated, nurse-driven approach can enhance efficiency, equity, and patient outcomes. Next slide. So the outcomes that matter. So the DNP project did highlight the success of the interdisciplinary collaboration by making sure that all disciplinaries were involved. And we were able to coordinate between nurses, different providers, and therapists to really create a unified wound care model. So patients experience faster healing, fewer hospitalizations, and greater satisfaction. We were able to achieve improved communication, streamline workflows, and reduce duplication. and resource use, showing that under a DNP leadership, the patients thrive, and then the nurses were able to really manage these patients and become more effective in managing their patients. Next slide, please. So implementing a interdisciplinary nurse-led service came with several challenges. I would say the most significant was the role ambiguity. I remember sitting in our meetings before I had to do my project in my institution, and the group was just different administrators and management, and sitting at like on the Zoom, and they're looking at me, I'm looking at them. So they're like, what are you doing? What is your role? How's this gonna help? So it was really helpful to have all the data, present the data to them, and basically just say how this can save the institute some money. So these patients are not having to wait so long to get into the visit with me and then go to the ER where they were not given the appropriate care, maybe just given antibiotics and really not addressing the core issue of why they have the venous leg ulceration. In addition to the role ambiguity, we had issues with limited staffing. My nurses were pulled from like just the general staffing, so they can be dedicated only to wound care. So they were pulled out of the endocrinology pool and out of the podiatry pool just to be dedicated to wound care. So that was a bit of a staffing, but we were able to kind of rearrange, and a lot of the other departments were very supportive and on board, and were able to make arrangements so my nurses could just focus on patients with wound issues and with venous leg ulcerations. Okay, and the next slide. So the vision for the future. So looking ahead, the future of wound care envisions interdisciplinary nurse-led systems as the gold standard for excellence. So we as DNPs, we lead the integration of data-driven, technology-enabled strategies, such as digital wound tracking. Right now, AI is huge in wound care, with wound assessments, telehealth consultation, and bringing the care to the patient's home. So global collaboration will expand knowledge sharing, allowing us to disseminate best practices and equity-focused interventions across care settings. So as we move forward, it's important that we really keep equity at the center and at the core of everything that we do to ensure that every patient, regardless of where they're located, their race, their gender, their age, has timely access to an expert wound care provider. We must continue to also champion policy that supports advanced practice autonomy and sustained funding for community wound care programs. Okay, next slide for reflection. So these outcomes highlight the core strengths of the nurse-led interdisciplinary model and reflect what the heart of what it means to be a DNP. For me, I consider wound care as my ministry. I'm in the room with the patient for anywhere, especially with a new patient, anywhere from 45 minutes to 1 hour, counseling, educating, we pray, we sing, we talk about the wound treatment plan. We're doing all of that. So each of us have a very unique practice area or specialty, whether it's advocacy, mentoring new nurses, going to the Capitol, making sure that we're also resting and we're being fulfilled. So each of us has a very unique place, and it's not by happenstance that we have our DNP. I believe united, we can truly make a difference. We're very powerful. We can actually, and it sounds very cliche, but we can actually change the world. We can change how healthcare is delivered. We can make a significant impact on patients and within our community if we're all united and we're able to really work to our strengths. So I'm proud to be a DNP. I'm proud to be part of this organization. I love doing wound care. Ostomy is my first love, but I was very proud of the nurses who were able to support me in this. I had an amazing mentor. And so I'm very, very happy with the way everything turned out. And for all of us, want us to take the time to really make sure that we continue to pour into ourselves so we're able to pour into others, into our community. Thank you all for your patience. I know it's late. If you have any questions, I'm all ears.
Wow. I'm over here just stupid grinning from ear to ear because, I have a confession. At the start of your talk, I thought, okay, wound care, ostomy, I don't know if this is the
I
talk
know.
for me. You've heard it
I
before.
know.
But when you started talking about gathering the evidence, doing the teaching, getting nurses to practice at the top of their scope,
Yeah.
and down to getting the time that people are waiting to get care.
Yeah.
Can you say those numbers again? It was very significant. Listen to this, y'all.
We started out of patients weren't able to get into the clinic for 19 to 21 days. And then
Uh-huh.
after the intervention, it was 8 days. And that was mind
Incredible.
blowing. So, and it's funny because, I read through the evidence, you read through it, it's like, okay, it's saying it's gonna work, but like, is it really gonna work? And it actually worked. And our healing time was 104 days to I think like 48 days.
Yes.
It was honestly it was amazing. The project was amazing. The patients were amazing.
Yeah.
To see it play out, I was floored. And and it just goes to show how at the core of it, we're just nurses. And so sometimes we have to kind of work with what we have,
Mm-hmm.
because they're not going to be handing out things to us. You have to work with what you
Right.
have.
Well, and you said in the beginning of your talk, you felt like you were begging.
I
And they were
begging.
telling you you're just gonna have to make do with what you have.
Correct. Correct.
If anyone believes in nurses, it's nurses.
Yes.
And that belief that you put in your team to practice at the top of their scope.
Yeah.
We heard about burnout previously.
Yeah.
Practicing at the top of your scope prevents burnout.
Yeah.
Right? Because you're working in a way that you went to school for. And, I think a lot of us who feel like, okay, well, I guess I got to go back to school if I want to do more, because the organization so many times lock nurses into this is what you do. But to have an advocate and a leader in a DNP to change all of that for your team, for your patients, that was incredible.
Yeah.
Y'all, I just want to thank all three of our speakers. What a robust night. I'm leaving with lots to think about. We will be back tomorrow on the same link for a talk on rural primary care impact and the organizational value of DNP prepared CNS leadership. Same link, same time. I look forward to seeing you all again tomorrow. And thank you once again to all the speakers. I'm going to hang back for about 5 minutes, but I'll end the recording. Um, excellent, excellent night. Thanks so much. And thank you
Thank
all
you
for
all.
suffering me in Dr. McKamey's absence.
You did an amazing job.
Thank you.
Best of luck with the rest of your DNP education.